understand what you're saying,
Yeah.
but do you know how difficult?
Back to education. The next one's chemical code. You being a nurse, let me ask you this question. If there's a code blue and we come out there with a crash cart and the patient says, I just want chemicals. Don't intubate me. Don't do CPR. Don't do the paddles. But give me those medicines. If I come out there with a crash cart and I'm not profusing and I'm putting a needle in their arm, putting this medicine, where does the medicine go? Nowhere. And so I go back to the physician and I go, you see a chemical code written on the chart. Did you educate them that it's not going to save their life? Well, no, that's what they said they wanted. It's like, well, that's not ethical to charge them for a crash cart knowing that it's not going to save their life. It's a package. So we kind of get back to in the education of the patients, because why I'm telling you all this, you're going to be a family member making this decision with your family, and you're going to be a minister and you're kind of going, understanding, oh, now I get the big picture, okay? Because you will be involved in this with your family someday, unless you pass first. Otherwise, you're going to be standing there going, now I understand this a little bit. Where did my changer go? There it is. Code blue statuses. There are 3 choices. A full code, and your hospital may word it a little differently. Full code meaning give me everything. A DNR with aggressive care means I still want to go to surgery, still want treatment, but I just don't want I don't want to be resuscitated. That's all I mean by that. And then the last one, a DNR with hospice, meaning they can't fix me anymore. Surgery isn't going to help. Why go testing this thing in the CT scan or the MRI? Why do all those testing? Because I don't want you to fix it anyway. So no more testing, no more treatment, no more of those things. I still may want to be here, stay here in the hospital, but put me on hospice care. Just treat the pain, treat the palliative issues. So it's kind of making a decision in those areas. And then the DNR, we actually had a patient in our ICU about 6 years ago that had DNR tattooed on his chest. And they did not have an order for a DNR on the chart. This was on a Saturday, and the nurses called me and go, Larry, we can't get a hold of the doctor. We don't have a DNR. And this man has tattooed on his chest. We've all laughed about this. I'm going to tattoo it on my chest. Well, he's got it, DNR. And I go, what I wanted to say later, I thought, you sure that wasn't his girlfriend's initials? Yeah. You know, well, I said, if you can't get a hold of the doctor and you don't know what this means and there is no order for a DNR, you just keep on doing your CPR or the paddle, whatever you need. They resuscitated him and asked him the next day, what about this? And he goes, well, I was a military pilot and I thought if I ever got shot down, just let me go. But thank you for resuscitating me. You know? Well, it's like we all kid about that. I always tell people, if you're going to tattoo it on your chest, get your doctor to sign it at the tattoo artist. Then you got it. Hospice care. All DNR patients are not necessarily ready for hospice. I may have a DNR, and I may say I don't want to be resuscitated, but keep treating. Keep doing those things that make me better, but I just don't want to be resuscitated one day. Hospice is offered for those who are dying. Most of the time the arena is like guessing that there's 6 months to live. You working with that plan too? Yeah. Do you have it here in the hospital where they can stay in the hospital on hospice?
Yes.
Do they have to meet the 2-week criteria, possibly dying 2 weeks here in this state? Okay. Some states are a little more particular if they're staying in, but maybe you have a hospice group that uses your facility as their hospice house? Okay, that's how it works. Must have a doctor's order for that. Hospice doesn't walk them down the hallway looking for dying people. You know, that's solicitation. They need a doctor to say, oh, they may come in and give some enabling and see that kind of thing, but you won't be a hospice patient without a doctor's order. Offers within 6 months. Hospice patients can get better. Quote unquote, there are patients who are in such writhing pain that don't feel like eating, and or else they don't eat, they don't get out of the bed, and so they're just kind of deteriorating, and then they go, well, let's quit trying to fix this thing. Let's put you on hospice care, and let's give you enough pain medications to cut the pain, and then they're like, I feel like eating. And then they start eating, well, I think I can stand up by my bed now, and start walking down the hallway, and they get better, quote unquote. They're still dying of some illness, but the family's like, wow, recovery, wow. No, we're not seeing that the cancer's gone away or the heart problem's gone away, but they get better for a while and can be discharged from hospice. They'll be back, but can be discharged from hospice if they're not meeting that 6-month criteria anymore. You're working on that too, the 6-month criteria here, where they can be discharged and back? Okay. Now, my wife in my living will states differently. My wife believes that I'm going to pull the plug prematurely and be married in 3 months. Now I tell her, honey, no, it's not going to take 3 months. Well, because I have attitudes like that, I know that in my living will, I have to state it differently, because she's going to leave me on life support and make me suffer. So we have to word ours differently. No, I'm just kidding. But living wills may be stated. You may get this form when they bring it to you and go, that's not quite the way I want it worded. Then type out your own and get it witnessed and get it signed. Or change the wording on that and initial your words without it. That this is, that's not quite me. So you can word your living will at your advance directive to fit your needs. Talk a little bit about organ donation. The organs that can be donated are heart, kidney, liver, lungs, pancreas, small intestines. The tissues are corneas, skin, heart valves, bone, ligaments, veins, and arteries. And the things that can be donated after death are corneas, skin, and bone. Even at the funeral home, corneas can be taken, skin can be taken, bone can be taken. But these things, tissues, these things, organs, are taken from a patient that's on life support, that is going to die anyway. And that the strong wording from is mainly brain death. But let me see if I can get to that now. Joint Commission said in 2008 that there are 92,000 patients waiting for an organ or tissue. And there are far too many people that aren't making this determination to be an organ donor, or your organ procurement rules are so tough the patient has to be brain dead, both brain and brainstem death, proven by 2 EEGs before we can take organs. So we're not talking about corneas and bone and skin, which is after death. We're talking about from a patient on life support. They go, your criteria is too tough. That what if a patient in cardiac death, if they died of something and they took them off life support, that we could take organs and rush them to the patient. They have a certain amount of hours, or every different organ has a certain amount of hours that can be viable. Well, what they thought was, those organs won't be any good. They're inside a patient whose heart wasn't good, or lungs weren't good, or kidneys weren't good. What they found was, after they started transplanting these organs from a bad body and got them into a good body, they were quite viable organs. Changed the whole plan of what they thought was going to happen. So they changed the rules in 2008, not just to be brain death. Now don't get worried that you're going to get a cold and somebody's going to take your organs, okay? It's still a very tough rule that there's cardiac death. And then they rush the patient to surgery and take those organs. But they're all ready, the team's all ready. It's not like cardiac death has happened. What is your procurement agency name in this area?
Lifeline.
Lifeline, we have that one too, yeah. And so they do that. They come down, evaluate the patient, and see if that's proper. Organ tissue donation will not affect viewing in an open casket funeral, no matter what organ, corneas or what organ. You won't know the difference. A lot of people are going, no, how can we embalm after this and have an open casket? It won't affect it. Up to possibly 50 patients can be helped. Now, that's the perfect world, that this organ donor is the perfect match for 50 patients out there, and blood type and tissue type, and that's rare that 50 patients are helped, but maybe 5 or 8 or 10 can be helped by that. And otherwise, organs are cremated or buried. I have a little bumper sticker that says, why take your organs to heaven? Heaven knows we need them here. It's kind of like, why don't we become more, what am I going to do with them? I don't need them after that. I've already been declared brain dead by several people, but at that time brain dead. I don't need them. maybe somebody else can help.